I'm a geriatrician specializing in palliative care. My topic today is an increasingly important issue: end-of-life care. For dementia patients, the care of dementia patients presents certain problems. Dementia is a terminal illness and is the third highest cause of death in Australia. But dementia is different from other such conditions. It has an unpredictable trajectory and there can be difficult issues around patients' mental capacity, decision-making and communication. But in spite of an equal need for palliative care services, dementia patients don't always fit the traditional model of such care. Families often suffer distress to ensure that their loved one's wishes are being respected, or just don't know what that person wanted. Because the discussion did patient-centered, palliative, dementia care that's available when and where it's needed. I do a lot of work with Dementia Australia, an organisation which represents the needs of Australians living with all types of dementia, and if their families and carers, as it also campaigns on dementia issues and funds research. Dementia Australia decided it was the right time to examine the issue of end-of-life dementia care, from the perspective of the consumer as well as from that of the healthcare professional. It's a timely initiative. We have plenty of anecdotal evidence but not enough hard facts about what's going wrong and why the system is failing. But the current situation isn't all bad. I've heard some wonderful examples of how it has made a big difference to people's lives. Things can obviously go badly wrong if this isn't handled well, but in the right circumstances people with dementia can reach the end of their lives peacefully and with dignity. Dementia Australia commissioned researchers to conduct a survey on the end-of-life issues affecting dementia patients. The survey covered both care professionals, that's doctors, nurses and others working with dementia patients, as well as family member carers. The interest was overwhelming with more than 1,000 responses from around Australia, but what do the results tell us? The initial results confirmed what we've heard about access to appropriate, end-of-life care. It was obvious immediately that there was a striking gap between the perceptions of care professionals and family member carers about end-of-life dementia care. For instance, while 58% of family member carers said that they didn't have access to palliative care specialists and 68% didn't have access to hospices, has 3/4 of care professionals indicated that people with dementia in their area do in fact have access to palliative care. This begs the question of whether consumers, that is patients and family member carers, might not be aware of services that are available. Another notable finding of this survey was that care professionals often lack knowledge of the legal issues surrounding end-of-life care. Some reports indicate that care professionals are at times reluctant to use pain medications such as morphine because of concerns about hastening a patient's death. However, access to appropriate pain relief is considered to be a fundamental human right, even if death is earlier as a secondary effect of medication action. Our survey found that 27% of care professionals were unsure about this or didn't believe that patients are legally entitled to adequate pain control if it might hasten death. So perhaps it isn't surprising then that 1/4 of former family member carers felt that pain wasn't adequately managed in end-of-life care. This lack of awareness extends beyond pain management. The statistics on refusing treatment were particularly shocking. Almost 1/3 of care professionals were unaware that people have the right to refuse food and hydration. And 1 in 10 also thought refusal of antibiotics wasn't an option for patients in end-of-life care. How can we ever achieve consumer empowerment and consumer-directed care if the professionals are so ill-informed? There's a clear need for greater information and training on patients' rights, yet over 1/3 of care professionals said they hadn't received any such training at all. It's obvious that end-of-life care planning is desirable. Discussing and documenting preferences is clearly the best way of minimizing the burden of decision-making on carers and ensuring patients' wishes are respected. Acted advanced care planning is essentially an insurance policy that helps to protect our patients in case they lose their decision-making capacity. Even though a patient might believe that loved ones will have their best interests at heart, the evidence shows that such people aren't that good at knowing what decisions those they love would make on complex matters, such as infection control. I'd like to talk to you today about some research I've been involved in concerning something that affects all health professionals and staff: patient communication. Now, firstly, let me reassure you that in feedback, patients seemed positive about the way information is communicated to them. But I am recently decided to explore the issue in more detail when I was in a hospital with the patient, and witnessed for myself what can result when a healthcare professional assumes they made themselves care to a patient when in fact they've been anything but. Luckily, I've had very few complaints made against members of my team, but the potential is certainly there. So first, let's start by looking at a typical hospital admission for an inpatient. Now, the first communication they have about any procedures they are to undergo on arrival, a patient will complete necessary paperwork. Various staff will talk to them about their treatment during this stay, which is designed to reduce patient anxiety. However, from some patients' point of view, this interaction can seem very complex and difficult to take in, especially in a time when they're not at their best physically or mentally. So, it's doubly important to check that any communication has been understood. Now, to illustrate what I'm talking about, let's take a hypothetical situation. I often use this because it highlights the potential consequences of poor communication. No man in his 80s is admitted to hospital despite his protestations with ongoing severe back pain. On investigation, it's found his cancer has spread there. Outlook is poor and further compounded by his becoming depressed and refusing to eat while in hospital. Feeding tube is inserted, a procedure which the patient complies with, but which his family members query. The doctor on duty updates them, assuming they're aware of the severity of the patient's condition, when in fact, no such prognosis has been shared with them, and extreme case, but a plausible one. Nevertheless, in order to find out exactly what inpatients felt about the service they were receiving in this hospital, we conducted patient survey. The questions were carefully targeted to capture patients' opinions about the effectiveness of the communication they'd been involved in during the estate. The survey questioned patients on both what they had expected prior to admission and what their stay was really like. These two scores were then used to calculate what's called a gap score. The survey also included questions to measure the patient's behavioral intention. That is, how willing they would be to return to the hospital for treatment. Patients completed the survey themselves, and results were then processed with the help of medical students. Now, the survey produced some interesting data about communication, including both and complaints. Clearly, in a hospital situation, staff are dealing with confidential and sensitive information, which must be communicated in private, a situation which can be difficult to achieve in a large and busy hospital. However, we scored highly on that point, and we were also pleased to note that staff did manage to communicate in a manner that treated patients with dignity and respect. Of course, staff also have to ensure patients fully understand what's been sent. This last point, where we received the most negative deeper, patients and relatives noted a tendency for professionals to resort to the use of jargon and complex terms when explaining both diagnosis and procedure, which left some patients confused. However, patients were generally satisfied with the information about any follow-up treatment provided after discharge. Also, once we'd sifted through all the results, and clear pattern began to emerge regarding the care given by nurses, which I found particularly interesting. I'd assumed that having a number of different nurses attending to a patient during their stay was a good thing, because you need enough staff to cover the various shifts and attend to patients' needs. What I certainly hadn't expected them was for patients to say, they felt their recovery was faster when they communicate with only a small number of nurses. Other words, when they were surrounded by familiar faces. The findings aren't conclusive and more investigative work needs to be done on a bigger sample, but it's certainly food for thought. Or attempts to contact the doctor within a year of their death, and up to 66% of people attempt suicide. Response to complete. Is important to realize that they need 3% of people who commit suicide or attempt suicide have had contact with the doctor within a year of their death, and up to 66% of people who commit more attempts suicide. I've heard such content within a month of the gate before, with better prevention techniques. These speakers could be reduced. We can divide suicide prevention into 3 categories, which are primary, secondary or tertiary. Secondary suicide prevention aims to decrease the likelihood of a suicide attempt in high-risk patients. Tertiary suicide prevention occurs in response to completed suicides and attempts to diminish suicide in a particular geographical area or in a particular age group. I would now like to look at secondary suicide prevention in more detail. As secondary suicide prevention is particularly important but not always give it the attention that it deserves, in part because research into secondary prevention is only just starting to be applied to clinical practice. Now, from a clinical perspective, suicide is often difficult to protect due to its complex nature. The 3 major risk factors that contribute to suicidal behavior: biological, psychological, and proximal stresses, which are recent events that can lead to increased suicide risk. Firstly, there are biological risk factors for suicide, which include low blood cholesterol levels, medical or neurological illnesses such as multiple sclerosis, stroke, Huntington disease and epilepsy, cigarette smoking. Secondly, there are psychological risk factors which include a childhood history of physical or sexual abuse, aggressive personality traits, low self-esteem and poor access to psychiatric treatment. Thirdly, there are proximal stresses or the recent events that can lead to increased suicide risk, and these include relationship problems with a spouse, partner or loved one, financial troubles caused by unemployment or large amounts of debt,